Which type of pocket is formed by gingival enlargement without destruction of the underlying periodontal tissue? That's a gingival pocket. Deepening of the gingival sulcus may occur by coronal movement of the gingival margin, apical displacement of the gingival attachment, or a combination of two processes. Pockets can be classified as follows: gingival pocket, periodontal pocket. The gingival pocket is a pseudopocket. This type of pocket is formed by gingival enlargement without destruction of the underlying periodontal tissues. All gingival pockets are suprabony. The best of the pockets is coronal to the crestal. The base of the pocket is coronal to the crest of the alveolar bone. The sulcus is deepened because of the increased bulk of the gingiva. Now, a periodontal pocket, which is the second classification of pockets, is a type of pocket that occurs with destruction of the supporting periodontal tissues. Progressive pocket deepening leads to destruction of the supporting periodontal tissues and loosening and exfoliation of the teeth. Two types of periodontal pocket exist: intrabony, in which the bottom of the pocket is apical to the level of the adjacent alveolar bone. Again, intrabony, in which the bottom of the pocket is apical to the level of the adjacent alveolar bone. And suprabony, in which the bottom of the pocket is coronal to the underlying alveolar bone. Clinical signs that suggest the presence of periodontal pockets include bluish-red thickened marginal gingiva, a bluish-red vertical zone from the gingival margin to the alveolar mucosa, gingival bleeding and suppuration, tooth mobility, diastema formation, and symptoms such as localized pain or pain deep in the bone. The only reliable method of locating periodontal pockets and determining their extent is carefully probing of the gingival margin along each tooth surface. Next, furcation involvements have been classified as grades 1, 2, 3, and 4 according to the amount of tissue destruction. Grade 2 is 1. Incipient bone loss, 2. Partial bone loss, cul-de-sac, 3. Total bone loss with through and through opening of the furcation, and 4. Similar to above, but with gingival recession, exposing the furcation to view. And I believe it's the second one, partial bone loss. Yes, the grade 2 furcal involvement, grade 2 is a partial bone loss. The term furcation involvement refers to the invasion of the bifurcation and trifurcation of the multi-rooted teeth with periodontal disease. The denuded furcation may be visible clinically or covered by the wall of the pocket. The extent of involvement is determined by exploration with a blunt probe, along with simultaneous blast of warm, asymultaneous blast of warm air to facilitate visualization. Furcation involvements have been classified as grade 1, 2, 3, and 4 according to the amount of the tissue destruction. Grade 1 is incipient bone loss. Grade 2 is a partial bone loss called cul-de-sac. Grade 3 is total bone loss with through and through opening of the furcation, and grade 4 is similar to grade 3 but with gingival recession exposing the furcation to view. Findings that complicate furcation involvement and account for some painful symptoms include caries in the cementum and dentin, tooth resorption in the furcation, abscess formation in the furcation, and involvement of the pulp via lateral canals in the furcation. Definitive diagnosis and furcation involvement is made by careful clinical probing. X-rays are helpful, but only as an adjunct to the clinical examination. The major principle of treatment of involved FARCA is to eliminate the involvement whenever possible. A variety of methods are available for treatment. Not all of them provide for elimination of the furcation. Some provide only for increased accessibility to plaque removal. Bone grafts have relatively little effectiveness in treating furcations. However, guided tissue regeneration is used to treat class 2 furcations with good success. Note, furcation involvement of maxillary second molars have the poorest prognosis following therapy. Important, microscopically, furcation involvement presents no unique pathologic features. It is simply a phase in the rootward extension of the periodontal pocket. Next, drug-induced gingival enlargement. Drug-induced gingival enlargement consists of a pronounced hyperplasia of the connective tissue and epithelium. That is true. Drug-induced gingival enlargement may occur in mouths with little or no plaque and may be absent in mouths with abundant deposits. Both are true. So, gingival enlargement is a well-known consequence of the administration of some anticonvulsants, immunosuppressants, and calcium channel blockers. Clinical and microscopic features of the enlargements caused by different drugs are similar. Again, they are a well-known consequence of the administration of some anticonvulsants, immunosuppressants, and calcium channel blockers. The growth starts as a painless, bead-like enlargement of the interdental papilla and extends to the facial and lingual gingival margins. As the condition progresses, the marginal and papillary enlargements unite. They may develop into a massive tissue fold covering a considerable portion of the crowns and may interfere with occlusion. When uncomplicated by inflammation, the lesion is mulberry shaped, firm, pale pink, and resilient with minutely lobulated surface and no tendency to bleed. The presence of the enlargement makes plaque control difficult, often resulting in a secondary inflammatory process that complicates the gingival overgrowth caused by the drug. Secondary inflammatory changes not only add to the size of the lesion caused by the drug, but also produce a red or bluish-red discoloration, obliterate the lobulated surface demarcations, and increase bleeding tendency. Anticonvulsants. The first drug-induced gingival enlargements reported were those produced by phenytoin or dilantin. Phenytoin. Other hydantoins known to induce gingival enlargement are ethotoin, which is peganon, mephenytoin, which is mesantoin. Other anticonvulsants that have the same side effect are the succinamides, like selontin, sarontin, and depakine. And these are okay. Now, immunosuppressants. Cyclosporin is a potent immunosuppressive agent used to prevent organ transplant rejection and to treat several diseases of immune origin. Cyclosporin-induced gingival enlargement is more vascularized than phenytoin enlargement. Another immunosuppressive drug, tacrolimus, has been used effectively and results is much less gingival overgrowth. It results in much less gingival overgrowth. Calcium channel blockers are drugs involved for developed for the treatment of cardiovascular conditions. These drugs are the dihydropyridine derivatives like amlodipine, felodipine, nicardipine, nifedipine, the benzothiazine derivatives like diltiazem, zem, and phenylkylamine derivatives. So, next question. When using the periodontal probe to measure pocket depth, the measurement is taken from 1. The base of the pocket to the cemento-enamel junction? No. The free gingival margin to the cemento-enamel junction? No. Junctional epithelium to the margin of the free gingiva? Or the base of the pocket to the mucogingival junction? No, I think it's junctional epithelium to the margin of the free gingiva. Yes, junctional epithelium to the margin of the free gingiva. Periodontal probes are used to measure the depth of pockets and to determine their configurations. The typical probe is a taper rod-like instrument calibrated in millimeters with a blunt, rounded tip. Ideally, probes are thin and the shank is angled to allow easy insertion into the pocket. The probe is inserted along the long axis of the tooth into the pocket with a firm, gentle pressure. Again, the probe is inserted along the long axis of the tooth into the pocket with a firm, gentle pressure, approximately 10 to 20 grams, until resistance is met. The probe is walked around each surface of the tooth. This method is less painful and more efficient, provides a complete and accurate assessment of the depth of the epithelial attachment, and will detect bony defects better. Periodontal probing provides the most accurate assessment of periodontal pocket depth. The true topography of vertical osseous defects cannot be determined by radiographic examination alone. Bone levels may be high, yet pockets may be deep. Extensive bone loss may exist, and yet be unaccompanied by pockets in the gingival if the gingiva has receded. The most important reason for using the periodontal probe is that it determines the loss of attachment. Notes: bleeding scores. Bleeding is still the most reliable indication of the presence of gingival and periodontal inflammation. 2. Plaque score. With plaque disclosing solution used to help visualize plaque for the patient and clinician. Also used at multiple visits to show patients improvement in their level of oral hygiene. Recession. Recession is measured in millimeters from the cemento-enamel junction to the marginal gingiva of each tooth root. Next. How should a periodontal probe be adapted in an interproximal area? 1. It should be parallel to the long axis of the tooth at the point angle. It should be parallel to the long axis of the tooth at the contact area. It should touch the contact area, and the tip should angle slightly beneath and beyond the contact area. Or it should be perpendicular to the long axis of the tooth in front of the contact area. And it should touch the contact area and the tip should angle slightly beneath and beyond the contact area. That is the correct answer. It should touch the contact area and the tip should angle slightly beneath and beyond the contact area. The periodontal probe may be angled approximately 10 degrees on each interproximal surface so that the tip of the probe is placed apical to the contact point of adjacent teeth and may detect an interdental crater, but in most instances, the direction of the probing is parallel to the long axis of the tooth. Periodontal measurements are taken by inserting the probe under the marginal gingiva and gently moving it down the junctional epithelium. Feels soft, elastic, and resilient. In a healthy site, the tip of the probe stops within the junctional epithelium, and in a diseased site, it penetrates into the connective tissue. In severe disease, the probe tip may penetrate to the alveolar bone. Note, the clinical probing depth is always greater than the histologic sulcus or pocket depth. Again, clinical probing depth is always greater than the histologic sulcus or pocket depth. Probing accuracy is only within plus or minus 1 millimeter. Note 2. The calibrated periodontal probe should have a tapered shaft approximately 0.5 millimeters in diameter at the tip. It is important to have uniform instruments throughout the practice to ensure as much standardization as possible. Note number 3, furcation areas can be best evaluated with the curved number 2 Neighbors probe. And note 4, the periodontal probe can also be useful in the detection of subgingival deposits. Furcation areas can be best evaluated with the curved number 2 Neighbors probe. Okay, so next. How should the periodontal probe be inserted into the sulcus? Answer: parallel to the tooth surface. The tip of the probe should always be kept in contact with the tooth, thus preventing soft tissue injury. The probe is gently walked along the junctional epithelium in an up and down motion called circumferential probing, always remaining under the gingival margin. It is imperative that the probe be walked along the entire gingival sulcus, since the depth of the epithelial attachment varies. 6 measurements are recorded: 3 from the buccal and 3 from the lingual. Distal buccal, buccal, mesiobuccal, distal lingual, and mesiolingual. These measurements are the distance in millimeters from the base of the pocket to the margin of the free gingiva. The base of the pocket is the junctional epithelium. Note number 1. The most important reason for using the periodontal probe is that it determines the loss of attachment. These measurements are taken both before and after scaling a root planning procedure to evaluate the tissue response and the effectiveness of treatment. Note 2. Probing is performed with firm, gentle pressure. The correct probe force, approximately 10 to 20 grams, depresses the thumb pad approximately 1 millimeter to 2 millimeters. If you should meet resistance after inserting the periodontal probe into the sulcus, you should remove the probe and reinsert it in a different spot, lift the probe away from the tooth and attempt to move it apically, force the probe beyond the obstruction, remove the probe and select one with a narrower diameter, record a measurement where the probe stopped. Again, if you should meet resistance after inserting the periodontal probe into the sulcus, you should lift the probe away from the tooth and attempt to move it apically. Often when probing, the passage of the probe may be blocked by a hard, unyielding ledge. This is usually calculus. Gently lift the probe away from the tooth, placing it against the tissue wall of the pocket and attempt to proceed apically again. If the obstruction is indeed calculous and it has now been bypassed, then the probe should now move deeper into the pocket until the junctional epithelium is reached. The tip of the probe should be placed back against the tooth once the obstruction has been bypassed. Remember, the probe should be inserted parallel to the vertical axis of the tooth and walk circumferentially around each surface of the teeth of each tooth to detect the areas of deepest penetration. Notes: recession is the measurement of the migration of free gingival margin apical to the cemento-enamel junction of the tooth. Recession is measured as a positive value. The recession measurement added to probe depth. The recession measurement added to probe depth at the particular site indicates the amount of periodontal attachment that has been lost at this site. When the gingival margin is coronal to the cemento-enamel junction, the recession measurement has a negative value. Again, recession is the measurement of the migration of the free gingival margin apical to the cemento-enamel junction of the tooth. Recession is measured as a positive value. The recession and measurement added to probe depth at a particular site indicates the amount of periodontal attachment that has been lost at that site. When the gingival margin is coronal to the cemento-enamel junction, the recession measurement has a negative value. To measure, and note number 2, to measure the amount of attached gingiva, number 1, place a probe on the external surface of the gingiva and measure from the mucogingival junction to the margin to determine the width of the total gingiva. And then, 2, insert the probe and measure probing depth. Subtract the probing depth to the total gingival measurement to get the width of the attached gingiva. Again, to measure the amount of attached gingiva, place the probe on the external surface of the gingiva and measure from the mucogingival junction to the gingival margin to determine the width of the total gingiva. And then insert the probe and measure the probing depth. Then subtract the probing depth from the total gingival measurement to get the width of the attached gingiva.